Hi everyone, and thank you for coming. A choral piece, Choralis Choralis, employs the human voice to invite audiences to explore trust in the use of artificial intelligence in medicine. A collaboration between Professor Andrew Swift, the medical school, myself, an artist, and the artist Michael Day, composer Michael Betteridge, Lucy Bramley, project manager and director. Choralis Choralis consists of a choral piece performed by singer from Kantos Chamber Choir and a panel discussion which provides audiences the opportunity to learn more about the project and the themes underpinning the medical and the creative work. Choralis Choralis is constructed from expert interview transcripts and forms a cultural counterpoint to the programme of pulmonary hypertension research in Sheffield, which uses artificial intelligence to improve diagnoses made on chest scans. Choralis Choralis aims to increase the understanding of AI in diagnostic medicine, staging a conversation with the viewer about the investment of trust in machine learning. Could I ask you to please welcome Kantos Chamber Choir to the stage?
AI is really a tool to improve what we do. So AI has been likened to the windmill. Before the windmill, people used to just mill the wheat themselves. And then they got the oxen to do it, and then they said, you know what, we can actually just put sails on sticks and then just turns around themselves. So it's just like something which does what you actually do. It does it without you putting any effort in it. And you just use available computing power, for example, to do the things that you do. AI doesn't come up with new methods. It comes up with improved methods.
All we need to do is teach this computer how to do it. We just drop on a few sample cases and provide the computer with this images,
with the measurements, and tell them learn the measurements
on these
to
images.
the network.
When you take
And they
the
do
model, you have to wait,
First thing,
look
manual
and behave
annotations
like
for that model. The
You're
model itself,
telling me that
model
it's
to
trained by a
invent its own
computer
kernels
scientist
or AI
So you
scientist, but
apply these
the manual annotations should be by a radiologist or
multiply with
multiply with the image.
to
As
get
much as we have information, the more you have
the synapse
that
that either, but instead it will be very complex model to deal with. They will deal with the model itself like as a result.
but you have many of
behind the scene. It's a very
kernels.
complicated model
Or
if you give it
filters.
something out
Each
of
one
the
is
ordinary
connected to many other
So
ones
for
in
example,
different
if you have a
layers.
new
Generation of and
the
signal for them is
either it's modulated as it goes through, so you get to the end and you compare your AI results as your reference truth, and then you go, okay, it's different in this way, somehow, but I gave that difference all the way through this. Now that I
It's like you train any animal to do anything. It's repetition.
The evidence shows that it's at least as good as humans. That's what the evidence says. Well, I do trust it. I've looked at the studies. So in a sense, I trust randomized controlled trials. That's where the evidence comes from. I trust evidence-based medicine. And evidence-based medicine says that technology does what it hopes to do.
And so there's no question of trust for me there. I think it's extremely important how acceptable these technologies are and how people, whether they trust them or not, and I think that it's linked to a feeling. And it is absolutely essential. I mean, it's absolutely essential if they're ever going to be introduced that people feel that they can trust the technology. Total blind trust is probably not a good thing in anything. When people meet us as doctors, they're expecting a level of training and expertise there. So even then, they're not trusting us blindly. But the training that you've had is expected, and that feeds into the trust in the profession. And I think that's going to be the same with machine learning, is people's confidence will improve. If they can see good outcomes, and they're seeing it in a regular manner, I think we need trust in the AIs, ourselves, and I think I don't think we're there yet. I don't think even my colleagues or my colleagues trust it. I guess it's with time, you know, the better these things get, the more trust you can have as a clinician, and then therefore the more trust you can then instill with your patients. But I think that comes with time. There are like social, cultural, structural, epistemic, organizational factors at play to the shaping of these technologies.
Drawing around a structure or an image, you know, it's not a particularly difficult problem. It's just one that takes time.
The software at the minute can do that, just running in the background. That has a time resource saving implication.
And then, the fact that we can do all of this work quickly and saving people time to look at techniques and you take away this bit of really clumsy work from them. And it frees them up to look at the case properly, just gives them more ability to use their time wisely for things that we don't yet have the capability for training a machine to do.
The trust on AI depends on the training of AI.
AI doesn't come up with new methods, it comes up with improved methods. AI is really a tool to improve what we do.
AI is not here to replace, it's here to help.
The better we get at engaging the right population, making these algorithms better, the more readily accepted they'll become.
Can I thank the choir, Kantos choir again, and now we're going to welcome the collaboration and the researchers onto the stage and take some questions. Get some chairs. Yeah. Can you sing the questions? I can't sing. I tried karaoke last night. It was a disaster. Somebody filmed it as well. There's a few more, yeah, isn't there? There's a few more.
Thank you.
Has everyone got a mic?
Yeah, just we don't need it.
I'm going to be an informal chair and just ask the panel to introduce themselves.
Yeah, hello, I'm Andy Swift. I'm Professor of Cardiothoracic Radiology in Sheffield, and we're starting to use AI a lot more, and I feel it's something that the public should sort of engage with and be aware of. But it's very early days in healthcare, so to get to sort of have it developed with the clinicians and also with the public aware is very important. And I really just want to thank Emma, actually, mainly to start with, for this amazing choral piece, and the choir and Michael and everybody. So thanks to them to start with. And also, I think this should be very sort of organic and a discussion about, because people who've come here probably have may have some thoughts on the AI development and AI generally. So hopefully between us we can answer those questions.
If everyone introduces themselves, then people know who to ask.
Hello, I'm Dr. Chris Johns. I'm a chest radiologist at Sheffield Teaching Hospitals. So I'm a clinical radiologist. I sit and report, and I'm at the coalface of delivering healthcare, I suppose, in Sheffield. But I'm interested in how artificial intelligence could potentially enhance delivery of healthcare in the region, but also more wider, particularly making sure that it's done in what I think is as safe a way as possible, obviously. So working with National Institute of Healthcare Excellence and the Royal College of Radiologists, just to see how best we can deploy AI.
Thanks, Chris. Thanks, Andy. And I'm Emma O'Connor. I'm, in this capacity, an artist, really, and have helped sort of bring the project together. I'll hand over to my colleague, Dr. Michael Day.
Thank you, Dr. Emma O'Connor. I'm Michael Day. I'm one of the artists who's involved in the project and helped produce the piece.
Thank you. My name's Ellie Slorak, and I'm the artistic director of Kantos Chamber Choir.
Thank you. Do we have any questions to start with? I have one question I want to, and then I'll go to the audience. How did the creative process come out? Because I was the festival director. That's a really interesting. Why did you see the need to use the choir in this medical research?
Thanks. Good question. The project began with a medical project and the need to engage audiences with some of the topics that they were facing using AI in medicine. And Andy approached myself as artist and researcher to talk about this. So we had a few chats, really. And actually it started 4 years ago, about 4 years, although it's been dormant for some time. And I approached Michael and we started discussing how we might work creatively with some of these themes. And specifically, the idea of using the human voice actually came about with a sort of happy accident when it was a mishearing between ourselves. And I think that Michael thought that I said, "What makes the heart sing?" And then this idea of singing just took root, and we kind of went with that. And it felt really important to use the human, something human, the human touch, the human voice, as a sort of counterpoint for artificial intelligence. I don't know if you want to say anything more on this.
Yeah, thank you. I think among the things that healthcare contexts offer is the opportunity to interact with other people. And I think when you receive news of a diagnosis, it's always the tone of voice of the person who's delivering that news, or the one-to-one human context of that interaction that really has a bearing on how that interaction is experienced. So I think from quite an early stage, we knew that the voice and the tone of voice of the piece was going to be quite important. I think initially we were considering the possibility of using recorded sound or using a kind of more ambient soundscape approach to this project. But yeah, we kind of made the decision that singing, I think, became quite an important aspect of it because of the way that it can, instead of the work approaching the audience intellectually by using tune and using music, it can cut through all that and get straight to the emotions. And I think a lot of the content, a lot of the material that we were using, the texts that we were using, they're potentially quite emotive and potentially can kind of, the whole topic really is quite an emotive topic. So for that reason, it felt like that singing and music was a good way of doing that. And also the power of a choir, when there's a bunch of people together producing a tone, that does something to a room, as we've just seen. It does have an effect emotionally on an audience. So that was one of the reasons why we opted for that option.
And the Council Choir, Ellie, how did you get involved?
Well, we got an email from Emma asking if we could do this project, and I think it needed a certain kind of quality to bring it to life. It needed people who would be able to, I guess, be open-minded to the project. And maybe I could just talk a little bit about the process that led to what you saw just then. We've actually had 2 workshop sessions before rehearsing the piece where we've basically asked the singers to just try loads of things. So we've had different ways of delivering the words. We've tried different ways of accompanying the words by just singing chords or by making a little riff pattern beneath it. And we've done, I guess, a lot of almost improvisation in the workshops to come to the final thing that has been written down and performed today. So yeah, that's, I guess, why this choir in particular came on board. We've got the right people in the group to do
And
that.
the right voices.
Exactly.
Okay, a young lady there would like a question.
Young lady. Hello. I just wanted to say that I thought the blend of text and music was very, very interesting. Do you normally do that? But there's a much bigger part to my question coming to the medics. Shall I say it now, or do you want? Yeah. Okay. I'm a deep-dyed cynic about a lot of things, and I am about AI too, in the sense that just like pharmaceuticals, we need to know and understand who owns Big Pharma. We need to know and understand who owns the technology of AI. And that didn't come across in the text at all. It was represented as innocuous as the wind. I don't believe that.
Do you want to answer that? Which one of the scientists wants to answer that? Well, the quiet bit first.
So for the words and the music blended, we do a fair amount of contemporary music, so we're kind of fairly used to doing things with words and music at the same time, or spoken word and music. We've not done a piece with this much spoken word, and there was a lot of so the words themselves are transcribed interviews. So there was a lot of the workshop time spent working out what's the best way to deliver that to an audience, and for what's the best way for the singers to have that written down. So they are notated in true rhythm to the way they were spoken in the interviews, but we played with the idea of some text being delivered in just a more natural style, so we can see the rhythm outline, but the singers are being a little bit untrue to what's written on the page to make it sound normal. But obviously then when you've got people speaking at the same time together, it's really hard because we all are different. We would all say it differently if we were given the same sentence. So there are a few things where we had to be a little bit more true to the page, and perhaps that sounded then less natural, to a listener. And guess that was part of the creative process, was deciding when it was going to be natural, when it wasn't. And also when there's multiple texts at the same time, clearly you're not going to hear all of that. You're not going to get every single word. So deciding which bits of text were okay to be layered on top of each other, and then which bits were kind of so poignant that they were left kind of really clearly for the listener. So that's how we got to the text.
Thank you. Yeah, the texts were all experts who had been interviewed, experts who are part of the research project that Andy's running. So there's a range of different types of experts. Some of them are experts in the technical aspects of AI. There's a whole section of the piece which is about the training of AI, which is a very complex, quite inscrutable area of work, which only really very technically able computing people can properly understand. And we wanted to get that across in the piece by making that part of the piece quite confusing, quite difficult to listen to, and quite with text multiply overlaid. But other parts of the interview transcripts, really the amount of interview transcripts that we got was enormous. We did 13 interviews. I think they were all about an hour long, half an hour to an hour long. So there's an enormous amount of material that had to be discarded, actually, in order to produce the piece or edit it out. There's plenty still there, actually. There's probably quite a lot of material that could turn into a number of different future pieces. But yeah, maybe you want to say a bit more about the interview process?
I think it was the question about the fear and the the issues about AI that the lady wanted answering. Yeah.
Yeah, I think the question is really brilliant because and it reflects a little bit about the well, in terms of your question about sort of big companies having access to all the data, and I think the people who were interviewed represent a subset of people, and the information you've got from those people is reflected in what you've seen, and that kind of reflects AI as well. That the people who were involved in the process absolutely represents what you've got, if you had a representation from much wider people, including people in the pharmaceutical industry, then some of those other things would have come out. And I think there's obviously been a really massive change in AI. I don't know how many. I don't know whether yourself are using large language models in a day-to-day basis, such as ChatGPT. You're not a regular user. So if you are, then you will realise the power of artificial intelligence that these big companies, new people who are so the people they've managed to then acquire very large amounts of the internet, and using very, very large computers with massive processors, they can create something that's extremely effective now because of the amount of data that they can get hold of. And the difference in healthcare is that people can't just get hold of that data because it belongs to the hospital. It kind of belongs to the people who've been scanned. So it's or we now project is imaging project, or the people whose data it belongs to. So that's the real thing, really. Those companies really need to have some kind of permission to have your data, and that's where the sort of trust comes in, I think. Whereas, if they did have access to everything, then they could make some amazing models that would actually improve healthcare hugely, and it would make a massive difference. But they can't because that process. So there's a lot of it's going to be a longer road, isn't it, to actually make models that really work well in the right environments and things. But also, you don't really just want in healthcare companies just taking over and doing everything. It needs to be developed in collaboration with the medics and the other people, and also with patients and the public. So I've gone a bit of a ramble. Do you want to have a
I think we had the robotics for 2 hours before, and there is a fear of what AI is leading people down, and there's a fear, especially in terms of their health and replacement. So I suppose that didn't come out in the piece, I suppose. It was a more beautiful and kind of melodic, and the wind and AI is great. Whereas if you interviewed maybe 100 people from the general public, it might have been a bit more tension and scared and anxious. I think anxiety rather than paranoia is anxiety. We've had a lot of stuff on AI in the festival, and that's the feedback we're getting, and that people are welcoming our colleagues and academics explaining it, because they start to understand it rather than being kind of given propaganda on one side or the other. So I suppose what you're saying, you're very neutral. The information, the data can help healthcare. How do you get to it?
I think if I can just add something that really came out of the interviews was the importance of time, and how maybe you'll talk a bit more about it in medicine, because you see technology moving really, really quickly, but in healthcare it's moving quite slowly, as from what I understand from the interviews is like a consequence of a really careful regulation, which is necessary, but also, maybe you can talk a bit, it slows the process down, but perhaps keeps it safer. The sense of time, really.
So I think that one of the real challenges that we have, AI, it's a massive topic, isn't it? AI is a massive topic. It could offer potential to help in all sorts of ways, not just clinical, but also back office activities. There's so much stuff that doesn't directly impact patients that could be automated a bit more and take humans slightly out of the loop. And the biggest issue we have is we have this sort of lack of people and lack of time to deliver services. So we have on one hand, you've got this sort of real challenge to deliver high quality healthcare that we want to deliver, and then potentially a solution for how to deliver it. But then in order to do that, you have to spend an awful lot of time finding how to train it, finding how to test it, finding out how to find out whether people want it to be used in that way. And the two at the moment are very difficult to reconcile, I think, in the NHS in particular. So we've got lots of academics working on really good models that potentially might help with all sorts of aspects of healthcare delivery. But the jump from going from that to then saying, here's the evidence showing that it works, and then this is how you would use it in your day-to-day work, and then this is how it will impact patients at the end of it all, is very, very difficult to achieve. And so I think we're still very early in that journey, and over the next few years I suspect we'll start to see bits and bits, more and more coming together. But I think at the moment we're in a sort of an early sort of conversation, really.
Question here.
Hello, thanks for the great performance there. And I think it's right to notice that AI is a very powerful tool, more improving the methods and stuff like that. But I think, especially in radiology, I believe it's a really exciting, the potential to really improve outcomes for patients. I was just hoping you could maybe tell us how far along the path you are with using it and stuff in the actual hospital.
Yeah, so I can tell you a bit about from the sort of the development side, and then Chris potentially more from the deployment side. I think firstly, I think we really want to keep the doctors and the physicians as the central decision makers in healthcare. So you're not looking really to, from my view, from my point of view, you're not really looking to try to replace anybody. You're trying to enhance and make people more efficient, so that they can deliver the healthcare much more efficiently, which I think is probably what's needed, actually. So I spend a lot of time doing things which, as a radiologist, which is not actually looking at the scan. I spend a lot of time, it might be making some measurements, or it might be involved with writing of the reports, or looking back at previous imaging. And a lot of this could be automated, particularly all the measurements and things like that. So a lot of the work that we've been doing is just automating extraction of anything that we would normally draw around. That could be automated by the computer, and you just look at the results. If you can see that the heart's been drawn around, or the lungs have been drawn around in the correct way, then you can extract then the volume information, or what things about the structure that can tell you whether the patient's abnormal or not. And that actually, it can all be automated quite easily, and then from that you can then potentially start to create a textual report, for instance, that can save you a lot of time, and you can actually spend more time engaged with looking at the images whilst that's happening in the background, and also looking back. Like as a radiologist, you'll get you get a referral which can be quite brief, and then you're looking at the images with some information. And one of the ways to make the best report is to actually have the best information that comes to you about what's happened with the patient beforehand, the context. So I think if you had AI improve a lot of the actual interpretation of the images, making the measurements, helping with the reporting, the efficiency side, then you could actually spend more time engaging with the scan and looking at everything else with the patient. I think freeing up time, as Emma said, is probably one of the most important things. So I think that's in terms of development of different tools. So I think all AI tools should be as explainable as possible. So that's why I have a preference in imaging for things like segmentation, where it draws around certain bits of the image that you can then look at and interpret whether that's worked or not. The opposite of that is where the AI just makes a decision. This person has this condition, and you don't have any of the workings out, like the lady said. You don't have the workings out to know how the decision's been come to. That's a little bit more scary, because if it goes wrong, how do you know if it's gone wrong and things like that? It might still work very, very well, and it might be effective, but I feel there should be a level of interpretability. And then in terms of actually, but as Chris was sort of alluding to, and he can talk about now, how do you actually prove the clinical value? And maybe I'll switch over to Chris in terms of the actual implementation of clinical.
So I'm a chest radiologist. So what I know about is predominantly related to the chest, but there's the rest of the body to look at. But in terms of Sheffield, we are sort of actively, we have a framework in place for deployment of artificial intelligence into a clinical scenario, particularly focused on radiology. But it's not just radiology; it could be any. There's all sorts of fields of healthcare that could be enhanced. In terms of where we are with deployment, we are still very, very early days. There's an awful lot of people working on data on sort of assessing how artificial intelligence algorithms may perform in clinical situations, how specific patient pathways might be impacted by those. And at the moment, we're still very, very early days in terms of working out where these things best fit. I'm particularly interested in looking at lung cancer and how to improve the diagnostic pathway for lung cancer. So looking at simple things like if we have a patient who has a chest X-ray that is suspicious for lung cancer, at the moment, if that chest X-ray ends up on a reporting pile that gets looked at after that day, hopefully, maybe a couple of days, looks at by a chest radiologist, gets reported, then someone has to highlight the person that requested the chest X-ray, say this looks abnormal. Would you like to do some, we'd suggest some further imaging. And then they have to contact the patient, get the patient back in. We have to find time that we can do the scan, then the scan has to be done, then it gets reported again. And so you can see that all of these bits add in small amounts of time, which all the way down the pathway add more and more and more and more in. Whereas if you can come up with a solution that doesn't require manpower or people power to try and speed that up and get rid of a few days, the processes potentially could be improved. The question is, what's the opportunity cost? If you are over-egging the number of patients that you want to do further imaging on, are you taking away scans that potentially could improve other people's pathways? And there's always this balance, I think, that needs to be struck. Identifying patients as quickly as possible, getting them down the correct diagnostic pathway, without taking away the opportunity for somebody else to go quickly through their pathway. That didn't really answer your question, did it?
It sounds like it's quite a bit of like regulation and ethical sort of things that are maybe holding up implementation of this.
Yeah, and I think there's a lack of real-world evidence is for me the key. I would never do anything the idea of standing up on stage and saying I'm going to treat this patient with this drug, and I think it works, but I've got no, there's no randomized control trial that tells you that a patient in this group versus this group randomized does better. You get laughed out of the room, and I don't. For me, it's no different for making a diagnosis. If you incorrectly make a diagnosis of lung cancer, say, and somebody goes for an operation, there is big impact there. Flip side, if you incorrectly say somebody doesn't have lung cancer, then the risks are quite great, I would say, and therefore, I think we still need a greater evidence base behind our decision making.
Gentleman there at the back.
Hello there. So just first want to say, yeah, really interesting piece. I really like it. It resonates with me because I did a PhD looking at how healthcare might be improved through digital technology, including AI. And I have a bit of a background in the arts, so it kind of brings together loads of stuff I'm really interested in. So thank you for that. I just want to go back to some of the conversation about this kind of risk and ethics and concerns and so on. And I know that you kind of brought in some aspects of that. I guess what I really want to get to is, for each of you, what do you think are the biggest concerns? What are you personally most concerned about? And what do you think are biggest risks and concerns and challenges? And what do you think the solutions are to try and address some of those things?
I can just hear quickly, yeah. And then we go down the line, maybe. I think currently the biggest risk is that they don't work well enough because they've not got enough training data. Therefore, the biggest risk is if something being accepted. One of the companies will sell it to a hospital, telling them how amazing it is, and that's the problem. Is the information might not be correctly portrayed. They might take on something that doesn't work that well, and there'll be a problem. So currently, I think being ineffective is actually the biggest challenge. And then when they become really effective in the future, the biggest challenge will be how to to keep track on it, and de-skilling of the actual staff, a bit like with people who can't map read anymore because of Google Maps. You don't need to be able to do it. So I think the current challenge is that it won't work properly, and the future challenge will be maintaining the quality of the staff.
For me, my biggest concern is how you show clinical effectiveness. So, how do you show the implementation of said AI application actually does what it's saying and does it well in a way that isn't biased towards any group? So, if you look at how something's trained, so you're going to invite people in probably for a body of research to have an algorithm trained on their imaging. You've got to make sure that is a very generalizable group of people that represents the whole population. Otherwise, when you deploy it, there is going to be a group of people who are not going to be served well at all. And then the problem with that is, once you've built that bias in, you've got to know that bias exists, so you've got to somehow find it, but then you've also got to do some sort of body of work that's powered sufficiently to identify that bias. So you've got to, you're talking about massive randomized control trials, huge data points in order to make sure that it works fairly in everybody and it's explainable.
I feel like that was a medical question. Well answered, thank you.
I'll have a go. Yeah.
Sorry.
Yeah, a lot of the language that we're using, we talk about trust, we talk about training. We're also talking about guidance from these systems in the sense that they're not replacing clinical interventions, they're enhancing clinical interventions. In an early version of the piece, we also wanted to include an interview with somebody who worked and trained assistance dogs. And we were looking for a metaphor to try and understand this problem. And while as humans we feel perfectly capable of trusting an assistance dog to take somebody who's partially sighted across a road, while not knowing what goes on in that animal's brain, it feels like with a digital or a technical version of that trust suddenly disappears. So for me, I think the biggest risk is trust. It's like there's a lack of trust in these systems and how the trust is earned by those systems, which comes from a body of clinical evidence that builds up to support the sense that it's going well. But yeah, I think for me that's the biggest issue. I don't know what the future risks might be. I will leave that to the medical folks, I think. Do you want to have a go? All right.
Can we have a question about the creative process?
I just basically want to ask a question in regards to what piece of research have we done in regards to sort of ethnicity, diversity? One of the reasons why I'm asking that is because many years ago I was actually diagnosed with having glaucoma, and I was on medication for 5 years, and it was only until I'd actually went to a newly qualified doctor who basically said, no, that's actually something that runs in the African Caribbean community. We have this dark shadowing behind the eye. So for all those years, I was actually treated for having something that I didn't actually have. But if that research had actually been done in regards to different ethnicities, then it's about information, basically, what's put into the system, and how do we actually manage and ensure that that's actually been scrutinised effectively. That makes sense?
Yeah, no, I think, and Chris was alluding to that before. I think one of the big challenges is making things work in diverse populations, and in different populations they'll have different prevalences of conditions, and I think actually AI can actually help with this, because there will be a bias in some hospitals where they generally only see certain ethnicities. So they're not used to thinking about the range of conditions that may occur in people who come from a different ethnicity. So AI actually has the potential, if we can get access to data. I think when I've spoken to patients, they generally want to share data if it's shared for the right reasons. And if we can have a much larger data sets from different hospitals, different communities, then you can train algorithms that can actually improve their practice and make people alerted to potential diagnoses that they weren't thinking of in someone coming from a different ethnicity. So I think actually well, I'm generally an optimist, but I think actually the potential is very, very, very good for people of different ethnicities in the future.
Can I just add something there? We had a whole debate about the programming of AI is biased, that the actual data set before, in a way like the history of design was biased against women, in the same way the actual people who are programming the AI are a particular kind of individual that is then biasing the data before it starts. So it could go on and on. It's like peeling an onion. I think just being aware of all of those factors is what good academic research is understanding conscious and unconscious bias, data sets, looking at modelling between each areas. So I think, medicine, and I've worked with many colleagues in the university, are aware of all those factors. So some way saying it's lagged behind is saying that actually the medical profession have been a lot more careful than other industries who've kind of leapt on it without thinking of some of the consequences. So the bias starts from the programming, unfortunately. But making sure those factors are brought in, control factors, helps. So I'm not being an optimist, we've had 2 or 3 social scientists who've done a lot of work on the bias of AI. Sad to say. Got a question at the back?
I really have thought that the juxtaposition of the spoken word when it was with a couple of people speaking, so it was kind of more artificial, and then the more natural rhythm was really interesting. But I just wanted to know how the decision to have it spoken instead of sung came about, like who decided that it was going to be spoken?
Ellie?
Well, it's Michael's piece. I was actually thinking the same thing. Was it always going to be a transcript of the interviews with kind of musical accompaniment, if you like?
I guess so. I think there was something about the interview transcripts that we wanted to retain. So there was something very honest in the way that people had very generously given their time to have conversations with us about this quite difficult material, sometimes taking time out from their clinical schedules to do this. So we wanted to honour that and to try and be as, try and transcribe that text with as much authenticity as possible, but also bearing in mind the fact that they may not wish to be identified by the things that they'd said. So there's a bit of a sort of gap between trying to retain a degree of anonymity for them, but also trying to honour what they've said and trying to be true to what they were saying. I don't think there was any question of those texts being sung. However, some of the rhythm and the cadence of the accompanying vocalisation has been drawn from the tone of voice and the pitch of the speaker. So there is a process that our composer, Michael Betteridge, who can't be here today, went through to transcribe the pitch of speech of some of the interviewees for certain parts of the piece, so that the melody kind of rises and falls. And also at times there's moments when the vocalisation, the vowel sounds that the singers are producing maps onto some of the vowel sounds that the speakers were making at that point in their speech. So I don't think there was any point at which there was a decision not to put a melody against what they were saying. It was more that we wanted to be fairly authentic about what they were saying, but still find a way of capturing the emotional pitch of what that overall message was in that particular part of the piece. Is there anything you want to add to it?
Hiya. I wanted to ask a question about potentially helping people with Alzheimer's, because as far as I know, people who sing to people who have problems with Alzheimer's, it brings them back to a certain extent when they're actually singing themselves or hearing music that they're familiar with, that kind of thing. So I wondered if there was some way of tracing different sounds that people have heard, and if the AI is able to pick up, oh yes, this particular song or this particular music pattern, this really helps people, and this one not so much, sort of thing. I just wondered if there's any research into that.
Should be.
Yeah, I'm afraid I don't know the answer to that, I'm afraid.
There's 2 Alzheimer research groups in the university who are working with music and music therapy. So I don't know if my colleagues will know about that, but there are There are. So we
pass
can.
it on then.
Yeah, I'll pass that on. But yeah, so there's different ways that music is used in Alzheimer's and dementia, but there's also a way of kind of patterns of recognition with looking at the neurons and then tracing the link to particular kinds of music and reaction. I sound like a scientist, don't I? I've had a whole 11 days of this. So yeah, I'll pass it on.
May I just jump in with one little thing, which I know they're doing at the Royal Northern College of Music at the moment, is they're basically feeding a machine loads and loads of music to for the machine to start to understand the patterns of the music, and at the end of the process, they're hoping that the machine itself will be able to compose a piece. I'm not sure what I personally think about that, but that's sort of obviously, you know, as AI is being used in medicine, so it is in music as well. So
yeah, we have
an interesting...
Guy Brown, who is a professor at the University of Computer Science, worked with Black Dog, and they did an AI piece with local coders as well. So they created their own music through code. So we had a whole session on last Saturday. About 180 people came to it. But I think the question was about using music in dementia and AI. So
but if you
similar process, isn't
Similar
it? Exactly.
process,
Yeah. And the way Spotify creates these playlists now, that's clearly picking up on the same ideas in music and creating a whole playlist for you.
I think it's the emotion.
So
it's the emotional response that my colleagues are looking at. What music actually creates
in someone's
chemical response.
Yeah.
So it's the chemical response which then reduces the emotional response. But I don't want to misquote their research.
Yeah.
One more question? Anyone have we got here? Yes.
You talked about the research that you're doing. You talked about how much research is being done in the AI in this country and how you share that information. And then, how much is going on in other parts of the world and how do you share that? And when you then hear about what's going on in other parts of the world and other countries, are there things that, or other countries specifically, that you are concerned about the work that they're doing? So sharing information in this country, sharing information across the world, and is there anywhere where you are concerned?
No, it's a very good question. I think there's a lot of biases in terms of the some individual research groups might be competing for research grants, and they might actually have different groups around the country who are all trying to develop very similar things. So that culture in academia doesn't lead to a very good way of everyone coming together to do that. Ultimately, people should just have a different model where we actually all share the data sets to create something better. But the way it's set up doesn't really lead itself to that. I think it creates a sort of groundswell, and eventually the companies will be able to take on those technologies that the academia have identified. But it's quite a long process, and it could be quicker, I guess.
In terms of how much is there, there's absolutely loads. Every medical conference I ever go to now is filled with AI talks and very little of anything else. I totally agree with what Andy said, that you only hear the positives, you very rarely hear the negatives, and that's because people are trying to promote their work, trying to get more funding. And so there's a real problem with a lack of negative data. But I think that's an academic problem rather than a medical academic problem, certainly. In terms of worldwide, I think there's a real problem with looking at healthcare delivery elsewhere in the world and comparing it to the NHS, because the models are so vastly different. You know, the way that we deliver healthcare is so different to equivalent nations elsewhere. So you can't lift what happens in the States or most of mainland Europe, really, because their delivery of medicine is so vastly different. You know, most of it's private healthcare systems. Most people do things in other healthcare systems, it feels like, because it makes money for the person that's delivering healthcare rather than because it's necessarily the best thing for the person that's receiving it. And that's a very sceptical opinion, obviously. But you know, I think it's very much down to delivery in the UK. I mean, there's lots of AI algorithms that are for sale that have been delivered, trained and deployed in other countries. And there's no reason I suppose we couldn't take those and see how they work in an NHS population and use them. But I think it's down. I would say it's down to us really as a nation to try and work out how it fits, and yeah, I think we're making reasonably good progress. It's like everything, it takes time, doesn't it? And the first people that you hear are people that are trying to promote it, and it takes a little bit of time before you start to hear this is the good side of it, but actually beware of these pitfalls and that side of it.
I think also it's the funding process, like my colleague said. If you get government funding or certain funding, it's got to be open access. The collection of everything's got to be shareable. If it's for a commercial or a pharmaceutical, then the data is kept. So as a university, we're very open and very committed to open source and open data, and all our research has got to be shown where that data comes from. But as academic council funding gets produced, so it's got to be or for something which is seen as a quick and easy fix. 10 years ago, the University of Sheffield tried to set up a big data with all of the hospitals in South Yorkshire and all of the data, on health, and it never took off the ground because people couldn't see the point of it. They didn't understand why you want to do this. And that have happened, it would have made a massive difference. But I remember working on that with my colleagues, and it was just quite amazing, the foresight of this female professor in the university, but the frustration at local administration level, because it would not just involves healthcare, it involves councils, it includes our doctors. The chain of information or data that was required was just immense. So it never happened. But then, then Google came along and started doing it for us, and then charging. So I think the possibilities, I'm far more aware of it in terms of what I know people have tried to do. And it's great. So part of this festival is to try and engage the public with what we do. So it'd be really great to know what more kind of engagement you need to know about this research to enable this research to flourish, isn't it? Because you are the public who hold the data. Final words?
Yeah, well, I mainly wanted to thank Emma actually, and Michael as well, and the full choir as well for doing such a beautiful performance.
And I'll just have a final word, which is just to say that this whole project, from a kind of working on it point of view, has been it's been really precious, because the different ways that we've worked together, I mean, we're all kind of experts in quite different areas, and the way that we've managed to communicate and to be with one another and sort of exchange and trust actually has been really remarkable. And I've never worked in any environment when it's worked so perfectly. So to me, it's given me a kind of a model for working together, with a lot of trust and just a lot of goodwill. It's just been a really lovely working relationship between all of us, and that's thanks to the people who've been in it and the time that we've had to do it, the money that we've had to do it. So I just wanted to say that. I don't know if anyone else has got any last words.
We just said that just before we came on stage for this, just that it's really exciting to work, obviously I work in music, and we rarely collaborate outside of that world. So I think for the singers and for me, it's just been a really exciting opportunity to delve into this other completely different world for us, but also to be able to work along, like we just said, alongside each other and work out how best to get these ideas to the page, to the performance, for it to mean something. It's a really special opportunity. So thank you for involving us.
Just one final last word to say thank you in his absence to Michael Betteridge for all of the efforts that he put into producing the score, which interpreted my quite rough and ready chord progressions into something that a choir could interpret and perform. He apologises for not being here today, but he's done some brilliant work producing the score for the piece and making sure the choir could actually perform it, because it was quite technical, I think, a lot of it. So they've done a really good job. Thank you.
Have you all been thanked? So can I thank everyone on the stage? Ellie, Andy, Chris, Emma and Michael. Can we thank you everyone? And great round of applause.